Thank you so much, Ahmed. Thank you so much for the invitation. Can you all hear me? Can you give me a thumbs up?
Yes.
Yeah, sounds really good.
Yes.
Well, great. Well, I really have to say it's quite an honor to be invited to speak with you all this for what is this morning in Nashville, Tennessee, and it's evening, I know, in Pakistan now. And I thought I would speak about a topic that is both thrilling for me, challenging, and somewhat haunting. And that is a lifelong passion for attempting to get better, if not master, the art of acoustic neuroma surgery. I'm coming to you from Nashville, Tennessee. I know some of Music City, known for our musicians and songwriters. It's a very beautiful city. It's a vibrant and growing city. 100 people a day have been moving to Nashville for over 10 years. This is a riverfront, and in a couple of years, we'll host the Super Bowl in Nashville. So Nashville will be continuing in its prominence. I am at the Vanderbilt University Medical Center, which is embedded on the campus of Vanderbilt University, a very historic and beautiful campus right in the heart of our city of Nashville. We do have seasons. It snows on occasion, but it's generally a mild southern culture. I have to say that I have memories of a trip that Michael Dewan, one of my colleagues and partners at Vanderbilt, and I took a year or so ago when we had the Aga Khan, and it was just an extraordinary visit on a lot of levels. Here's some pictures of us having opportunities to meet and connect with students and residents at the amazing course that you all put on and were kind enough to include us. You know, we met students, we had a tour of Karachi, we had an incredible trip, and it really sort of solidified the relationship that we have between Vanderbilt and AKU in particular. Here's a picture of us with some of your team. Some of these faces are very familiar to you, and several have actually visited Nashville. Saqib, for example, visited us at our home. Michael and I learned something about cricket. We the great fortune of really understood that this is essentially, you know, how cricket's played. Dropping the ball apparently is not a good thing. We have trained a number of Aga Khan stellar superstars, notably and most recently Sonia Goodell, who is, I have to tell you, is just one of the most magnificent surgeons I've ever worked with. She is just truly gifted, and it's jaw-dropping to watch her operate. And we had such a joy training her and to see her on through her fellowship with Danny Prevedello at Ohio State in Skull Base, and now taking an academic job at Cooper. Currently, we have one of your proud graduates, Fatima, working as a postdoc with us in our department, and this is Fatima passing out candy on our front porch on Halloween, and that's her brother there. This was just the having her there, and just all the students and residents and fellows that we've been able to mentor over the past several years. So I want to talk about acoustic neuroma surgery, and it's a little bit of a different talk. I want to talk about decision-making, some notes on complications, and really some of the nuances, some of the things that I've begun to appreciate are often not sort of discussed in talks or even articulated, but I think they're important. And then at the end, we'll just wrap up by talking a little bit about NF2, a super complicated problem. I'm always just astounded by the variability of acoustic neuroma patients, both radiographically, and here you see just sort of the kinds of problems that we encounter as neurosurgeons and neuro-oncologists and ENT neuro-otologists taking care of these patients. These are all the same tumor under the microscope. Yeah, pathologically different in terms of how they're presenting, anatomic challenges, clinical challenges, as well as we'll delve into. But I think that really, to me, it really starts out with decision making. I think that you think about all the different possibility, all the different potential variables that go in to our decision making, and it's really just important to articulate that for a minute. This is one of my favorite analogies. I like to show the residents this EKG and point out that the decision making really starts in the outpatient clinic. To who are we operating on, who are we not operating on, who are we following conservatively, how long do we wait, how often do we repeat the images, what's the clinical picture. I tell our residents that the inpatient hospital stay is like the spike on the EKG, and that's essentially their whole world, and they aren't really aware of who we're not operating on. And then moreover, once patients leave the hospital, there's a whole world of follow-up, with them. We were talking about all the complications earlier, spinal fluid leaks and wound issues and hydrocephalus, things that manifest in the outpatient setting. So the decision-making really spans the arc of a patient's care from clinic to the hospital back to clinic. So I think about different sort of variables in decision-making, and you can kind of break them down. And so from a patient perspective, age, I think, is really an important issue. If you've got an 18-year-old, or you have an 82-year-old, what's their general medical health? If you're thinking about recommending a long, 12-hour surgery, is somebody going to be able to tolerate that or not? What's their job? I had a patient one time, memorable, whose job it was, his job was to jump out of airplanes. And I asked him, what's his goal with his 3-centimeter acoustic? He said, I want to jump out of airplanes again. And I said, well, okay, that may be a reasonable goal. We'll try to see if we can get you there. But that's very different than somebody who has a job where they're working on a desk, for example. And goodness, if you were a trapeze, a high wire trapeze artist, that could be a different situation. What's the hearing status? And there's objective ways to figure that out. But for me, I always ask people, do they have functional hearing? Is it useful hearing for them? And also the variable of disequilibrium, imbalance and disequilibrium. And we all are aware that these patients can present with some combination of hearing loss and disequilibrium. And it's almost sometimes independent of the size of the tumor. So there definitely are patient-related variables. So when you think about other algorithm, certainly there are tumor-related variables. How large is the tumor? And by the way, I think we all should agree on codifying what we mean when we measure a tumor. If it's a 3-centimeter acoustic neuroma, what are we measuring? What axis are we measuring? To me, the relevant axis is the largest diameter in the CP angle, not the long axis of the tumor. So it's also really interesting to me how patients, if you get on the Acoustic Neuroma website, they define themselves by the size of their tumor. They'll say, I'm a 3-centimeter acoustic, or I'm a 1-centimeter acoustic. It's striking. How fast is the tumor growing? There are different rates, and I for sure there are definitely patients whose tumors grew at some point and plateaued. And as you follow them out over time, they never change. Others, are surprised that they'll grow in 6 months. Another tumor-related variables we'll see is the vascularity of the tumor. I kind of will sort that out, because we all know that if you are operating on a large acoustic neuroma, sometimes it's a dream situation. There's no vascularity to it. There's a nice capsule. You can work within it. And then there are other times when every single surface of the tumor, every millimeter of the tumor you touch is just bleeding. And try working around a tenuous facial nerve in that scenario. So the vascularity of the tumor, I think, is really important. And I would love to explore maybe some ideas about how we can use different imaging parameters to help us know that before we start the operation. Finally, there are other variables. Are there other tumors? And then some tumors are cystic. And earlier in my career, I used to think, well, that's great. Cystic tumors ought to be much more straightforward to remove. But it turns out they're actually much more challenging. The thin wall of the cyst sometimes splays out the facial nerve, for example. And then there are other sort of variables that brain or anatomic variables. Is there edema? Is there hydrocephalus or not? Is there brainstem compression? Is it symptomatic? What about just the skull base anatomy? Is there a high jugular bulb, for example? That might be really important in terms of selecting your approach. And then really just kind of understanding the temporal bone anatomy. There's a huge degree of variability in the temporal bone anatomy. Sometimes you can drive a large truck through the temporal bone, and sometimes it's extremely narrow. And I think a lot of times anyway, as neurosurgeons, we don't really sort of take that into account, but it's something I think that we need to think about. So you think about all the patient-related variables, the tumor-related variables, and the anatomic-related variables. You got to put all those together, individualizing, decision-making for any one patient. So let's talk about some patients. So here's a 32-year-old musician from Music City in Nashville, Tennessee, who had some headache, and he has this small acoustic neuroma, and he has perfect hearing. So what are we going to do? He's totally healthy. He's young. His hearing's intact. He's got this tumor. He's completely, nervous about it. There are options. You could follow him. You could use stereotactic radiation, or you could remove this. And if you remove it, you have to decide whether you want to, think about a hearing preservation approach. And in a situation like that, if the decision was to treat it, I think a hearing preservation operation, might make some sense. And so, there's a group here within our group that has a very extensive experience with middle fossa exposures for hearing preservation for these small intracanalicular acoustic neuromas. And by the way, the tumor really needs to be localized to the IAC like it is here. It can't really extend out into the angle if you're going to do a middle fossa approach. We don't do as many middle fossa approaches as we do translab or posterior fossa approaches, as we'll talk about. But we do have, quite a bit of experience with it. And this is just a video. Let's see if it just showing you some of the exposure here. Working around the arcuate eminence, superior semicircular canal. This is all extradural. I'm taking down the dura, and then just sort of watching this play out. I really like a lumbar drain in cases like this because then you have a very wide exposure. The brain is much more relaxed. As you can see, we're not, having to use a retractor, at least in the beginning. ENT really likes these retractors. I sort of insist on these relatively smaller retractors rather than their large ones. Here's the beginning of the exposure. Our ENT colleagues are drilling out the IAC in this middle fossa exposure. And constant irrigation is really important because that drill can heat up. Even the diamond drill can heat up. And so just kind of watching this play out a little bit as the drilling kind of commences here. And just beginning to expose a little thin sheen of bone, constant irrigation, tiny little micro instruments for this.
Dr. Thompson, I hate to interrupt. We're seeing your presentation in presenter's mode. Is there a way to...
Oh, okay. Yeah, let me see if I can do that. How do I do that? Hang on a second. I don't want you to see it in presenter's mode.
You may have to unshare and then maybe share again.
Hang on a second.
Might be in display settings.
Display settings. Yeah, let me see display settings. Swap
and swap. Yes.
Is that better?
Yes. Thank you so much.
Thank you. Sorry about that. I can't really or what I'm not seeing. This is now sort of the intradural beginning of the dissection, and a second ago you saw a little bit of the anatomy, but here's sort of the sweeping motion, always kind of taking that tumor gently away from the facial nerve. There's the eighth nerve, there's the facial nerve here. Again, this is that middle fossa exposure. I really think it's important to know that you really have a harder time doing this operation once the tumor extends way down into the angle. You have a relatively small working corridor, but nonetheless, here's the vestibular nerve, and the tumor is going to just kind of roll out. It's a really nice exposure. I think you need to do, like any of these operations, quite a number of them to sort of get really comfortable. And here the plane of dissection is being developed by these tiny little micro instruments. And then eventually, there's the seventh. And of course, you're monitoring the nerve during this exposure. It always looks bigger than I think it always looks bigger looking at it under the microscope that it does on the MRI. It's always kind of impressive to me. Our expectation in these operations is perfect facial nerve function, but we know that that's always it's always at risk. So we counsel patients, but our experience in general is really pretty favorable with facial nerve. Okay, so
Dr. Thompson, before you
Yeah.
move on to the next
Yeah.
case,
Yeah.
I just wanted to hear your thoughts on the decision making in this case.
Yeah.
Just
Yeah.
for everybody.
Right. So yeah, and we're going to get into it some more too, but let's just talk about that. And I appreciate that, Omar. So I'll tell you, I think that every center who treats patients with acoustic neuromas has a bias, and others don't. And even surgeons have their own biases. So I'm really careful to discuss with patients. My general feeling, and you know, I've worked with David Haynes, my neuro-oncology colleague, for 21 years. And I like to say we're an old married couple. We finish each other's sentences. We're very different people, but we think alike. And we are actually really conservative. So that patient with intact hearing with that small tumor, I would have watched them. Okay, I would have watched them with a 6-month MRI, and I would have wanted to see a tiny little bit of growth before I intervened. And of course, you're risking hearing that way. But in my general feeling is that if you could hang on to your hearing as long as possible, that might be a good thing. All right. So, but there are patients who come in who basically, you know, are convinced, and this happens more often in places like New York or Philadelphia or other cities where there are multiple centers. People kind of shop around, you know, and they come already treated. They know exactly how they want it treated. And so I think that if the decision, you know, in this case with a 32-year-old with intact hearing was to treat it, then a really good approach is a middle fossa approach, because you're not, a translab is going to take out their hearing, and a retrosig, it's a little hard to turn around the corner to, if you will, to drill out the IAC. And I'll show you some other cases of that. So I think it's a really important question in decision making, and that's what, and there's so many variables that go into it. And I think that it's really, you know, patients should be empowered to make these decisions, but they need to make them in an informed sort of way, and it's got to be data driven. And I'm not even talking about radiosurgery in this talk. So, but of course that's always an option too. But again, the bias plays in there, and I tell patients, I'm very upfront, we have a bias. If we're going to treat you, it's towards surgery. Particularly true for me in my patients who are in their 20s, 30s, and 40s. I just don't want to radiate them if I can. Because why? I don't know what the outcome is going to be in 30 years. And honestly, in our center, in the last 6 years, we've seen 3 sarcomas in patients who've been treated 20 years ago with radiosurgery. And so I think we may see that playing out in the next decade or so. And there are sporadic cases, so you don't really hear about these malignant transformations. Okay, so I got a lot more on decision making, and Omar, I hope that answers your question to some degree.
Thank you.
So yeah, really key. In fact, that's almost the take-home point of the whole talk. So let's just flip the script for a second. Let's say that this is the same tumor. This is the exact same MRI, okay? But this is now a young person, a nurse, who's completely lost her hearing. So very different clinical, but can't get up and walk across the room, all right? Completely symptomatic from disequilibrium and ataxic. And I think what we've learned is that those patients, we can speed the resolution of their symptoms. And these are, I'm talking about not just minor disequilibrium, but can't hold a job as a nurse, disequilibrium. We've seen that. And often it's early on in the course of these patients while the vestibular function is being kind of taken out, if you will, on the side of the tumor. So we have a pretty low threshold actually for treating these people surgically, because our experience is that we can, I think, speed the resolution of their disequilibrium by removing these tumors. And in this setting of no hearing, we would do this translab. And we'll talk a lot more about the sort of indications, how we do it. But it's a beautiful approach. Patients go home, you know, usually on the 3rd. And we'll talk a lot more about, you know, the difference and nuances of the approaches. But it's the same tumor, but the clinical script flips and the decision making is different. It is the same, but you arrive at a different conclusion. Okay, what about this? What about a 1 centimeter acoustic neuroma, 61-year-old, hypertension, maybe diabetic, profound hearing loss? All right, we're not going to get the hearing back. It's a pretty small tumor. There's no edema. There's no hydrocephalus. It goes out a little bit of the IAC. We would watch this patient. We would watch this patient. We would repeat an MRI in 6 months, and then we would do it every year. And we played that out, and then a year later, it grew, and it grew into the angle. I think once the tumors sort of start to grow, that's telling you the trajectory is that they're going to continue to grow. And so we made the decision here to remove this tumor. Surgery is surgery rather than radiosurgery. It's a whole other talk, but the topic of radiosurgery. But nonetheless, we took this out translab. There's the fat graft. Patient did well. Okay, that to me is pretty straightforward. But what about this patient? Okay, this is a little harder. This is a 2 centimeter acoustic neuroma in a young person, a musician, lots of musicians in Nashville, who presented with headache. All right, their hearing is intact, their balance is not an issue. This is an incidental finding, essentially. But it's a 2 centimeter tumor. What are our thoughts about decision making? We could observe this. We could use radiation. All the parameters filter down into do we treat you or not? And if we treat you, when? And if we treat you, then with what modality? So if we're going to treat you with a surgical resection, what's our goal? Hearing preservation. I'll be honest with you. I have a really hard time, and I was trying to figure out the number, over 30 years. And I find that while we can, in general, preserve some type of hearing in a 2 centimeter acoustic, in general, it's not all that functional. Maybe that's just my inexperience, but that's the reality for me. And so we're not really talking to patients. We're not really focusing on hearing preservation if we're going to remove this tumor. And I'd like, maybe we can have some discussion about that. Maybe your experience is different. The other thing to point out is that, the other anatomic variable is this so-called fundal cap, where the tumors, stop short of the cochlea. Once a tumor's grown into the cochlea, you're not going to get hearing back. At least that's my sense. But if it stops short of it, you might have a shot at it. But I actually believe that there's a fair amount of so-called hearing preservation surgery, retrosigmoid, where the tumor is just really partially resected, and they've left the extracapsular dissection alone. That might preserve some hearing, but I'm not sure it's really all that advantageous because 40% of the tumor remains. So we asked the question years ago and published this paper, which at the time was the largest series of single institution experience at Vanderbilt, where we watched patients' tumors over time. There were 564 patients, and we wanted to understand, what was the growth trajectory. And it was pretty interesting to me, and it's almost sort of intuitive, but this graph shows you the difference in terms of the presenting size of the tumor. So in green, these are small tumors. These are patients whose tumors are basically they're less than a centimeter, okay? And then if we follow them over time and we define growth as 2 millimeters of growth in any dimension, it basically took 77 months for half of those patients to show some type of growth. But if you come down on the bottom in this Kaplan-Meier curve, when patients show up with a 2 centimeter tumor, like the previous case, if that's what we see in the beginning, 50% of those had grown or had been treated within a year. So what I carry around in my head is that if you have a 2 centimeter tumor, it's going to grow. And in particular, if you're young, it's going to grow. And so I basically, in that scenario, will say, I don't want it to get any bigger if we're going to treat you surgically. I don't want the facial nerve to be any thinner. So we would be having a much lower threshold for treating a patient based on this. This is our data that I think supports that. And I think it's just kind of intuitive, but here's the data. So what about this patient? Okay, 3-centimeter tumor, 57-year-old, hearing loss, disequilibrium. We're going to remove that tumor. And a 3-centimeter tumor is getting to be a large tumor. There's some brainstem compression of the cerebellar peduncle there. No hydrocephalus, no edema. We're going to, and it goes, by the way, all the way out to the cochlea. We're gonna take this out translab. And as an aside, I trained at Hopkins, and my mentor there published his series of over 1,000 acoustic neuromas. And I thought I was really, really well trained, and I was at the time I left. But I had done a grand sum total of 0 translab approaches. Why? We just didn't do them. That was not the bias was against translabs, and I didn't know how to do it. But coming to Vanderbilt, which really is one of the oldest neuro-oncology programs in the country. Basically, there was a fellowship for neuro-oncology in Nashville, Tennessee, and virtually Mike Glasscock was the fellowship, Glasscock's Triangle, for example. That was in Nashville, and all leaders now across the country, many of them department chairs, some of them deans, did their fellowships in Nashville. So we've had a 50-year history with the neuro-oncology group here of doing these types of surgeries. And when I got here 21 years ago, it took some convincing for me to learn how to do it. And I'll tell you, I'll give you some nuances in a minute as to what I've learned about how you can learn as a neurosurgeon to work with your colleagues to do these approaches. And my feeling is that patients actually do quite a bit better and they recover faster, but we'll talk about that in a minute. What about this clinical scenario? Got an 81-year-old, okay, 81, hearing loss, but falling. Why are they falling? It's a cystic tumor. What are our options here? Treat the hydrocephalus. Maybe we could do a subtotal resection of the tumor, depending on the patient's, sort of medical status. So, it's a different sort of clinical scenario, and the decision making here might be to consider even a subtotal resection with or without radiation thereafter. So, what about this one? This is a young medical student with a massive tumor and edema and a compression of the fourth ventricle. Clearly, they need, an operation. We're not going to treat this with radiation. We're not going to watch this. And a retrosigmoid approach, might be good here. And we'll talk again some more. So one of the things I wanted to just highlight here is that in the posterior fossa exposures, what we do is we tag team these, and we will get in there and we will find the seventh nerve. You can see it there over to the left. This is a right-sided exposure. You see the jugular foramen here, lower cranial nerves around the corner here. We will get in and we will use the CUSA or the sonopet, and we will take out, I like to take out about 75% or 80% of the tumor if I can, and really, really internally debulk it. And then our ENT colleagues come in and they drill out the IAC. Now, I will tell you that in very large tumors where there's not a very large component that goes out the IAC, we're not going to do that. We're not going to spend the 2 hours or an hour and a half to drill out the IAC. We're going to remove the posterior fossa component of the tumor, and we might leave a little sheen or a little shell of the tumor. So I think that it isn't like, at least in our practice, it isn't the case that every single posterior fossa or retrosigmoid approach we're drilling out the IAC. This is just sort of a video sort of showing some of the steps in drilling out the IAC. And again, our ENT colleagues do it. When we really are trying to, remove the tumor completely, when there's a large component of the tumor in the IAC, as well as the angle. But I also think there's a timing element, and we were talking about that earlier. These cases take a long time, regardless of the approach. I keep a clock in my head, and I want to have, we roll into the ORs at Vanderbilt at 7:30 in the morning. I want to have 80% of that tumor gutted by 12:30. Now, usually it's by 1 o'clock, but by then we can turn it over to the ENT, and then it'll take them about an hour and a half. And so now you're talking about, 1:30 or 2, and then we come back in and together we remove the remaining part of the tumor. And then, that I think buys us some time. So we sort of gut the tumor. You see it's gutted here. And again, you see the facial nerve over there. We've seen it at the brainstem, and then a significant amount of it. And then if we decide to drill up the IC, we'll do it at that point and move quickly. over time, we've gotten faster. You know, years ago when I had red hair, it used to take a lot longer to do these cases. We don't rush through them, but they're still long cases, and you sort of have to be aware of that. We'll talk a little bit about that too. So I want to spend a few minutes talking about some notes on complications. And you all have heard this phrase, but I keep this in my head. Every surgeon carries about him a little cemetery in which from time to time he goes to pray. A cemetery of bitterness and regret of which he seeks the reason for certain of his failures. And this was René Lariche, a very apt quote for taking care of patients with acoustic neuromas. And I'm haunted by it. But many times the residents wonder, you know, when we're doing an operation, why I'll say, oh, wait, don't do that. And I think it's because, you know, you build up a library of all the bad things that have happened, you know, to you, and you form the judgment. So I think about complications can occur in a number of different realms. They can occur from cranial nerve injury. It can be vascular complications. You can injure the brainstem or cerebellum just with retraction, perhaps, or vascular injury. Spinal fluid leak and managing CSF is another sort of realm. Infection, and then I would throw in, and we'll delve into each of these briefly. You know, there are other realms. For example, just the environment in the operating room, and also I'm going to talk a little bit about ergonomics in these long cases. So, what about just the cerebellum and brainstem? I think, you know, you've got to really individualize the approach. When we do our retrosigmoid approaches, we always put patients in the park bench. And the reason we put them in the park bench is it minimizes jugular venous compromise. If your neck is turned and you will plump up the petrosal vein, all the veins in the from raise the thoracic pressure and compromise venous return. So we want the neck beautifully positioned, and park bench really does that. So we pay a lot of attention to positioning. By the way, these cases are so long, you got to really take care to pad people. And not true in Karachi as much as it is in Nashville, but people are very large in Nashville, and so they're going to be lying on their bodies for 12 hours. So positioning is really key. I think you really need to take the time to get the exposure. There's a lot of discussion about retractorless surgery, and I get that, but I want to be able to use two hands. So I'll selectively use the retractor at times when I need it, or if I need to go deeper, I'll put it in. I never dictate in my note that I'm retracting anything. I'll say we gently elevate the cerebellum. Okay, so language matters there. But I think it's okay to put it in a retractor. Okay, like I don't think that's wrong. And surgeons in our group always are horrified, and I'm like, proudly a dinosaur. I'm going to use the retractor, but you minimize it. And again, getting the brain to relax, getting spinal fluid off before you really start the dissection, I think is key. We'll talk for a minute, and I'll give you a case example of where we staged surgeries, but we often don't do that. For example, this case here I'm showing you, we would do that in one sitting. We wouldn't stage that. But I'll show you an example of where we did stage it. What about the approach? We've been talking about it. I think it relates to your experience. Someone as experienced as Arthur Nam, I'm not going to argue with you, Professor. Absolutely, you are masterful, I'm certain, at the retrosigmoid approach. Do it. It's in your hands. It's perfect exposure. Don't change a thing. But I work with a bunch of ENTs who really like the TREDS lab, so I've had to learn how to do it myself, how to do it. And I've learned that in general, for me, the cutoff is about 3.5 centimeters. If the tumor's bigger than that, I'm doing it retrosig. I find that the window in the TREDS lab is very narrow, and sometimes it's even more narrow because of a high jugular bulb or just the anatomic variability of the temporal lobe. And I have a hard time seeing the tumor rostrally up by the tent in a really large tumor. Even when you got it, you have to reach around corners. That is not the issue with a retrosigmoid. You see everything from the tent to the medulla, so you get a beautiful exposure. I think if there's hydrocephalus, we often will put in an EVD. I'm not a big fan of putting in lumbar drains in these patients with large posterior fossa tumors. It just goes against my grain. Although I would like some discussion, maybe you do it and have some experience with it. And I think some of our younger surgeons do that. That if I'm putting a lumbar drain in and it takes 2 hours to do the exposure, we might cause some type of herniation. of course, there's approaches, considerations, as we've talked about hearing preservation, if that's your goal. And I also think it's really important to look for this high-riding jugular bulb. And I always look for it on the coronal cuts. The coronal cuts here tell me if I'm coming translab, here's the jugular bulb. We're only going to see about 2/3 of that tumor. So you're reaching around the corner. I think that's an important variable. You got to individualize the approach, translab or retrosigmoid. Again, that my cut for this patient, I would do it posterior fossa. But the translab approach has some advantages. It's really a pretty direct approach to the IAC. I mean, it's the first thing you see. And I think you pick up the seventh nerve earlier. By the way, I don't believe that there are differences between outcomes with regard to function, depending on the approach. I don't think that's a variable. This minimizes cerebellar retraction. You don't put people in pins. I had to really learn, like, wow, you can do a craniotomy with just turning the head. You're not putting them in pins. Yes, it's more of an ENT approach. It's less familiar. It's a smaller window, and there's a higher rate of CSF leak. We've almost, we've not eliminated, but we dramatically reduced our CSF leak rate by putting in a fat graft and closing off the bone with a cranioplasty. It buttresses the fat. So the very familiar approach to neurosurgeons, retrosigmoid, it's our bread and butter. As we mentioned, you get a really wide view. I think if there's hydrocephalus, I get better control of CSF. If I'm not putting in a drain, I can get the cisterna magna open. I can open up CSF spaces. Here, though, you've got to push on the cerebellum. And we talked about the park bench position in that setting. As I said, here's a pre and post-operative view of a large acoustic that we were able to successfully treat through the posterior fossa. Here's a case that's very unusual. It's probably one of the largest acoustics we've seen in a pretty young person. But look at the component that's eroded into the temporal bone. I mean, it's eroded and it's completely blown out the IAC. She was in trouble from the posterior fossa component of this tumor, and so we did a retrosigmoid approach. And then we staged it. In the middle view here, you can see we just shaved it off, got everything out of the posterior fossa, and let her recover. And we let her recover for about 4 months. And she went through physical therapy. She got her balance back. She was doing great. She was wondering why the heck we were recommending an additional operation. But she sailed through the translab on the staged. And you can see we left a small sheen of tumor right around 7 and very gratifying. Normal facial nerve function, and we've been following that small remnant without radiating her. She's a young person in her 20s. So there we staged it. One of the things I think is important when you're looking at films on acoustics, we talked about it earlier, is to look at the vascularity. Look at this image on the left, and you see this large vascular structure. And of course, where is it? It's probably an arterialized vein, dilated all along the brainstem and cerebellar peduncle. I think you just need to pay attention to that. I would love for us to have better imaging to understand the differences, as we mentioned, vascularity. By the way, I'm not a big fan of sacrificing the petrosal vein under any circumstances, not even in an MVD if you can avoid it. I think that you can get away with it most of the time, but not all the time. And it's often the case that you can dissect around it. If you can. I'll try to avoid it if I can. Obviously, you're thinking about monitoring cranial nerves. By the way, I'm going to throw out a challenge. And here's the challenge, and I would like you to accept the challenge. I would like, before I retire, to have the ability to see the facial nerve fluoresce. We monitor it and we hear it. But what about coming up with a fluorescent dye? Let's say you inject it in the face, and some retrovirus carries it to the facial nerve, and the facial nerve lights up. You put a little filter down, you see the autofluorescence, or in this case, maybe the enhanced fluorescence, and you actually see the nerve. That might be a really innovative thing. So I bet you some brilliant people in Pakistan can figure this out. And if you do, let's collaborate on that, because I don't want to retire and have this idea just end. I've thought about it for the longest time, but as is typical, no shortage of ideas, just shortage of time. anyway, I'd love to think about innovative ways for us to identify these nerves, and I think it's possible. There's some literature on it, but not much. What about spinal fluid? Okay, we were just having a conversation before we started about doing a beautiful operation, and post-op day 2, the patient's ready to go home, intact facial nerve, and they're leaking spinal fluid out of their nose. You just need to account for it. You need to release spinal fluid. We talked about getting the brain to relax. I think having an algorithm that works at the time of closure, really paying attention to that, really trying to seal things up, whether you need to sew in a dural graft. For the translabs, we always use a fat graft. And as I mentioned, we buttress that fat graft. Our CSF leak rate from the translabs dropped from about 18% to 3% when we adopted the fat graft and the cranioplasty. I was a skeptic. I was like, how could putting a cranioplasty in stuff going to leak? It seemed to. So, and then assiduous management of post-op leaks, I think. If someone's leaking translab post-op day 1, we take them back, and ENT looks for the source of the leak. If they're leaking a week or 2 later, many times we'll try to manage it with a lumbar drain. What about infection? I think these are long cases, and we don't appreciate that. Multiple teams scrubbing in and out, scrub nurses and techs scrubbing in and out. Those are variables for infection. I think are really important. And again, CSF leak being a notable one. What about other things? What about surgeon-specific variables? I don't think these are as well appreciated. This is some of the nuance I wanted to talk about. These are very fatiguing operations. You need to kind of be aware of that. One of the things that we've done at Vanderbilt is we've been experimenting with the light in the OR. And my favorite color is purple, so color in our rooms. This is our skull base room. And I think it relaxes me. It relaxes everybody. We play music in the OR. By the way, this picture is Sonia Goodell, your proud AKU grad, doing an operation when she was chief resident here in a purple room. These are really long cases. I think the older you get, the more gray hair you get, the faster you get. But especially when you're starting out, you just have to be aware. I cannot focus longer, intensely, under the microscope for much longer than 4 hours on an acoustic neuroma, especially if it's bleeding, especially if it's just every surface is bleeding. You just get fatigued, you start cutting corners. And so I'm really mindful of that. And we work, as I mentioned, with our neuro-oncology colleagues as teams, and we have a tag team approach for these cases, especially the long ones. There are other factors. By the way, this is also a picture of Sonia as a chief resident here on the right, in a case with one of our other residents, Becca Reynolds. A couple of other things we've noticed is that, of course, the temperature of the saline, really cold saline, the facial nerve does not like that. We've actually had a terrible complication where when we do the cranioplasties, we mold the material in a hot bath. And unfortunately, an inexperienced person, when we were asking for saline, gave them boiling hot saline, and they just injected it in the facial nerve canal. By the way, I think the heat from the microscope is also a variable. You can burn things. You can burn the dura. You can burn the soft tissue. You can burn the nerve. Put your finger in front of the scope for a minute and feel how hot it is. One of the most important variables, really deserves its own slide, but I put it here, is having a cohesive, experienced team. When I walk in the room and I see my team, day in and day out, year after year, I like to say my blood pressure goes down. If you have a team that is not experienced, that is nervous, or communication breaks down, these are not the cases for that. Okay, and I've learned that over the years. So we really push to have a team. A couple of other things. I think it's really important to have some stability of your arms. These 2 chairs on the right are newer chairs that we use. I think they're great. We use them for our most of our anterior approaches to the anterior skull base, but also the retrosigmoid approaches. They don't fit all that well in for the park bench position, but they do some. Dr. Haynes, who I work with, uses this chair off to the left, and I've actually sort of learned that for the translabs, I can rest my arms and have some support, but it doesn't really support your back. But having a chair, understanding fatigue, head in a very funny way on these long cases. And after a while, I developed a cervical radiculopathy, and I think it was just ergonomics. And I think you need to be aware of your body position when you do these cases. Okay, so for the trainees, a couple of notes. How do you start doing this? Okay, you're not going to be as a master like Author Anam, day one and probably ever, but you can start somewhere. And so start with the basics. Understand the anatomy. Go to the lab, work out these approaches, talk to your NT colleagues. Assist initially, as you're a resident, assist under the microscope. Get used to passing instruments in small spaces. Train your hands. Learn to begin to dissect the arachnoid. You're not going to start taking the tumor off the facial nerve in the beginning, but you can take down the arachnoid and maybe along the aspect of the tumor where the facial nerve isn't. Begin the, I try to teach our residents to begin to bipolar the tumor and then enter it and start to remove it. We use this instrument called Sonopet. It's a beautiful instrument for removing the internal aspects of the tumor. And then you sort of step up. Then you start dissecting the tumor off cerebellum. Then you figure out how to dissect it off the brainstem, how to lift it off. And finally, you move up to the really challenging aspects of dissecting off the seventh nerve. But what are the general principles? Understanding the pathology, working as a team. I think it's important to really articulate your goals before you go in to an operation like this. I think you need to individualize the approach. I think you need to gain exposure, gentle handling of tissues, and get the brain to relax and be patient. Some other anatomic principles. I think you need to understand the anatomy. Of course, cranial nerve function is key. I don't sacrifice. Try to manage and even avoid CSF leak. Understand the ergonomics, and I think also importantly, know when to stop. And don't spend 2 hours or 4 hours trying to get the last little sheen off the facial nerve in a 4-centimeter tumor. I think that's really sort of problematic. Leave it. We do, and we follow those patients. I have, and most importantly, I think it's good karma. Okay, like have a great team. Listen to music. By the way, I love this picture of in the Sistine Chapel, Michelangelo painting God superimposed over the sagittal image of the brain. And here's the brainstem down here. Okay, so here's the thing. I have a bunch more slides on NF2, but I'm not going to talk about NF2 because it's another talk. So I'm going to stop in a second and take some questions. But I wanted to. I think when you give a talk and people don't know you, I think it's also nice to sort of things a little bit. So I want to just take 4 slides to show you some of the things that I'm really passionate about. This is my wife and I hiking in these mountains, which I know to you look like just small hills, foothills. This is not, the Baltoro Glacier. This is not K2, but these are the Rocky Mountains in British Columbia, and we like to go up there and hike. And we did that. We've done that for several summers. We climbed this peak. This is a Via Ferrata climb. We did that this summer. If you zero in, these 2 folks in blue down on the bottom, that's my wife and I. It isn't as crazy as it looks. It's an incredible. This is me climbing up by this waterfall, and this is a video of my wife climbing next to a waterfall in British Columbia. Some of the things that we like to do that bring us a lot of joy. All right, so let me stop there. I've just been talking. I wanted to spend some time on NF2, but that's another topic. So let me sort of end there and open it up to questions. By the